Succes i veterinær praksis, podcast nummer 163. Hej, velkommen til. Dyrlæge Søren Pejstrup her. Dagens emne er på en måde lidt et svært fordi at vi ret hurtigt kommer ud i nogle meget stærke følelser, både hos os dyrlæger, men også hos ejerne. Og vi står ligesom midt i det hele, og skal på en eller anden måde holde den faglige fane højt, og få gjort folk og ejere opmærksom på nogle sundhedsmæssige problemer. Men samtidig skal vi også, uden at sige det direkte, fortælle dem, at de er måske nogle dårlige dyreejere. Og så skal vi strække os lidt ekstra for de her dyr. Det er alt sammen en meget svær balance, og det skal vi snakke om i dag. Og sædvanen tro kommer vi også ind på de sådan lidt mere filosofiske, politiske emner i dagens podcast. Men vi kommer også omkring det mere konkrete. Hvad sker der inde i de her dyr, som ikke kan få luft? Og hvordan skal vi gå til dem rent fagligt? Det er et spændende interview, så lad os kaste os ud i det. Hi Stefan, welcome to the podcast.
Thank you so much for having me, sir, and I'm really humbled to be here today.
So we're going to talk about a very interesting topic, and a lot of the clients and a lot of the patients I have in the clinic where I work actually fall in the category of what we are going to discuss today. So I personally find it a very interesting topic, and when you suggested it, I thought this is actually a very good idea. Let's talk about that. But before we dive in, what is important that people know about you before we start?
I'm not sure if there's a lot of importance here, but basically I don't take myself too important. But maybe if you want to know about my personal history as a vet. So yes, I was born in Germany. I studied in Hungary and moved finally to the UK after completing a residency for internal medicine. So I work exclusively in clinics and referral hospitals since I did graduate, and was very blessed to get a residency for small animal medicine. In the UK, I work currently as head of department of a big referral center, and I am. For me, it's with all my heart. I'm a clinician. I love my patients. I love the interactions, and it is for me of high importance, not only morally and ethically, but really to improve situations. And of course, as soon as I see patients, we have to be honest, right? I'm the last stage, basically before they die. So if they have a chronic illness, this is when they see me. Then owners are frustrated, financial concerns, and so on. So I have to have excellent communication skills, I would say, and be, of course, also on top of my knowledge to provide excellent care. And I take this very seriously. And I do this also with all my heart. So all what I'm going to say is really with heartfelt warmth from my side, and I hope I can also maybe reach some people also with my knowledge, especially with the topic we're going to discuss, what I acquired recently myself, and get to more read about it, the more almost upset I get about it, and I would like to share this knowledge with the community if someone is interested.
But it was your suggestion that we should talk about brachycephalic dogs,
yes.
and you've done webinars and lectures on this, so you of course have it the knowledge very present. But aside from that, I'm curious, why is it important to you to talk about this topic?
So I think it's still underestimated, and I also got the feeling in ourselves as vets that we lost the sensitivity a bit for these patients. So I tell you a situation. Let's assume you are in a waiting area. Waiting room, and a brachycephalic patient comes in for a routine appointment. You hear the severe breathing. What would you do? Would you prioritize these patients, or would you let them wait, although it's a hot, warm summer day? And what would you do? I admit, before I started reading more and more about these problems, I would have said, okay, you guys wait until you are up for your appointment. Mm-hmm. Now I say, as soon as this patient is here, it's prioritized, even though he's not he's too early or whatever, or he's too late. This patient is not waiting. This is what has changed for me after understanding how severe this chronic hypoxemia is, and also to understand how severe the systemic effects are. And the more I read, the more studies I find, the more goosebumps I get seeing these patients. And from my side, I want to overemphasize that it must stop. We must prioritize this patient, and we must stop breeding in such a malformation.
Yes. So usually we talk for more than 2 minutes before we dive into the philosophical questions, but I have one of the top of my head now. So we will of course dive into some of the more concrete stuff of what we have to do with these patients. But I have to, if I have to be honest, when I see some of these patients, I know it's not the patient's fault that it looks and breathes in that way.
Yeah.
But I can't help it to put that somewhat back on the owner. It's somewhat their fault, and they bought that dog. So why should I make an extra effort? And the others that also have an appointment, they will be 10 minutes late because I rearranged the program.
Absolutely.
And it all starts with a stupid owner that bought the wrong dog, right? And I have to be the patient.
I agree. Look, it's always the vet pays for it. Always the vet pays. We totally get that. And I so feel your frustration. And this is the problem what we have also with these owners, right? Because when I did graduate, I was, when I spoken to clients about brachycephalic problems, they were all like surprised. This has significantly changed in the last 10 years. Owners are aware that there are health issues now, but still they choose on purpose these breeds because this is a special type of owner we have in brachycephalic breeds. They want this cuteness. They're looking for these dogs because of appearances. They know these days now, most of them, that this is not a healthy dog, and they despite that they get this dog. This is why it's so important our communication not to get frustrated. They are aware I'm getting a sick dog, right? Mm-hmm. But despite that, they want this cuteness, right? This is why, from my side, absolutely agreed. They should have a Tamagotchi and not a dog, 100%. This is our challenge to deal with this. And is, after all, if there is no legislation who says stop this, then these animals are here. And for me as a vet, I take this seriously. I am here to stand up and say, okay, they have no lobby, at least not even from the veterinary community most of the time. So I have to say, look, we must change here something. So I think as long as there are no clear legislations and rules, this will happen. And I have to be, then the only thing I can do as a vet is with my moral stand up to say this must stop. So, and I do the best as I can to help. This is how I try to deal with these people. Although I feel your frustration, but this is the only thing I can do. Okay.
So both of my bosses are very skilled surgeons, and they have actually, we have in the clinic where I work taken more of these dogs in, and we've as soon as we started talking about these things, I have a sense, I don't have data to back this up, but I have a sense that more owners are listening to what we actually saying and say, okay, I would like to have some kind of surgery or something done to this dog to help it. So there is also a large group that know they have a sick dog and are willing to actually do something about it.
That's good. Yeah. This is I highly supported, and imagine how crazy it is in the UK. So I was not aware. In Germany, we don't have that. But here, the diplomates of surgery are also specialized in either soft tissue or orthopedics, for instance. So, and just among the soft tissue specialists are even more specialists who are specialized only on brachycephalic surgery. And I was a bit pushed in this brachycephalic topic because I'm working close with a colleague who is specialized in brachycephalic surgery. And she basically approached me all the time with all the problems the dogs have. And I started to read this up because I knew, of course, they have problems, but I was not aware what tip of iceberg is actually coming after all these breathing problems. What is all linked clearly to this abnormal breathing, this chronic lack of oxygen. And this is actually the fact, right? They have a confirmed lack of oxygen all the time. I mean, how would you feel if you can't breathe, you can't properly eat, and you can't sleep? And I was not aware that this is the case in this severity. And this is why I'm here today. And this is why I highly encourage as much as I can to raise awareness what brachycephalic means, right? So, yeah.
So my thought was actually, if we rewind a little bit, that my first question was going to be what type of dog that comes into the clinic, aside from the obvious very brachycephalic no-nose dog, but you somewhat touched on this in the beginning, so you can actually hear the dog, and it's stressing and it's breathing heavily when it's in the waiting room. But is there other dogs that we should be aware of that we should pick up, maybe in the phone or when they come in with something else?
So this is what also shocked me significantly now in these studies, that even if you think they are not crossly affected, so we have, as I'm not sure if you're aware, that BOAS, or the brachycephalic obstructive airway syndrome, has certain grades. And usually these grades are also according to their exercise intolerance, according how severe is this breathing sound. For instance, if it's already in resting, if you already have in resting a breathing sound, then of course this is a much higher grade, right? And I personally thought, if I don't hear anything and they appear reasonably active and whatever, for me, normal, let's say, despite that, they had changes in their inflammatory markers. Despite that, they had lower oxygen levels. And despite that, they had a higher grade of hypertension, which is linked to the sleep apnea. So, and this has shocked me. So these patients were also, for instance, hypercoagulable, making them as a higher risk patient for getting thromboembolic disease. So, and I thought, all right, they are sort of stable. Let's breed with them. But no, I must say, even they have health issues. So in my eyes, all brachycephalic breeds are considered in danger for me to have problems. And this is why they must be treated as highest priority, even their breathing sounds normal to you. Mm-hmm.
Yeah. And can we pick that up in just in a normal exam for vaccinations?
This is the difficulty, right? So it's, of course, a questionnaire you have to ask with the owner. How is the dog during heat? Is the dog obese? Obesity is always a risk to make everything worse, right? How old is the dog? Is an older dog? Of course, this is a progressive disease, right? So this is getting worse over time. This is linked to several factors, connective tissue, and so on. So it's almost impossible on a physical exam to pick this up. These are blood tests which need to be run sometimes in expert labs or things like that. It's shocking, and I was not aware myself. I admit that, and I also signs like this occasional vomiting, for instance, of white foam. I thought, it's a brachycephalic dog. I would have never thought that this could be the tip of the iceberg of a permanent, ongoing reflux problem. And then when I started to read about this, I started to ask the owners more questions, even though these animals appeared healthy. So what's happening in the night? Is this a restless dog? And often when I hear then, oh yeah, we have other dogs which are not brachycephalic, yeah, they sleep much longer, they sleep much less restless, or they are not pacing, for instance, in the night. And then I wonder, oh wow, does this dog actually have a silent reflux disease? And no one picks up on that. And the more I ask, so basically the more I read about it, the more I ask, you won't see any abnormalities other than brachycephalic problems very likely in your physical exam. It's for you as a vet, and this is what we medics, what we do, right? We ask questions non-stop. We ask specific questions. And this is the art also as a specialist probably to pick up on all these things what the owner tells me. Yeah. By the way, this is what I do as a training with the people I'm working with. So if I have an intern or a resident, I ask them separately to take the history of a client. I ask the intern to take the history first. Then I send in the resident. And then I go, independently, we compare then our history. And you would not believe that we always have 3 histories. You would not believe that this is the same patient. But this is the experience, what you get over time to ask the right questions with your experience, what you look out for, right? So, and it sounds like we have 3 different patients all the time. I do this out of fun when I start working with someone new, and we continue with this, sometimes occasionally, and then we compare again, just what the difference is. And this is very interesting also for maybe the younger vets here, how important it is to ask specifically questions. Just not, okay, a dog is coughing. Ask when a dog is coughing, for instance. How is the dog coughing? Is it productive, unproductive? Things like that. This gives you so much information. And you can save a lot of diagnostics already thinking about which organ system is most likely involved.
Yeah. So I've not done it a lot of times, but I've tried. I have one client that come to mind because I was asking if the usual basic question, is it eating okay? Is it the feces okay? And the answer was always yes. He's fine. He's fine. And I asked him if the dog was vomiting, and I asked specifically, is he vomiting from time to time? The answer was no. And then we start talking more about his eating habits. And then he actually moved on to say that he actually spits out this white foamy vomit. So I thought you said he wasn't vomiting. No, he doesn't vomit. He does the other thing.
That's right. Yes. And
he was actually a bit. It wasn't going great, and he was a bit irritated with me. And I wanted to talk to him about that. That was an issue, and he somewhat laughed at me, or he was irritated and said, "No, that's normal for this kind of dog." So you shouldn't make up a problem where there isn't one, he said to me. So and we somewhat disagreed on that, but it didn't end well. But I would leave it at that. But my point of the story is that you have to somewhat be very specific, because if the owner doesn't perceive it as a problem, you would you cannot ask if there is any problems or if there is any vomit, because you would have to ask specifically for that information.
I think this is the skill as vets, what we need, because the owner knows everything, right? In the fraction of time I see the animal, I will never, ever get this information out. And this is why for me, as especially now working then in they see me as, I don't know, the 10th vet or so, I don't know. I have to create very quickly an emotional safety. Did the owner feel safe to tell me things, right? So, and I asked him very specifically, so tell me a bit about your day. How is he in the night? How is he during the day? How is he on walks? Because, for instance, vomiting of white foam is very common after exercise in French bulldogs, right? So I'm trying to pick up on that. Is he sometimes eating grass? Sign of nausea, latent esophagitis, for instance, right? Or and I think, sometimes he does, and I think, oh, that's interesting. This is important for me to know, right? I try to encourage this. I give them like a little, let's say, praise, right? So that and then they tell me more, and how is he eating? Is he eating all at once, or is he eating a bit of a picky eater? Oh, and they say, oh, he's a picky eater all his life. He's very choosy. I think, oh, this is for me an important sign, because why would any dog be a picky eater? They are not picky eaters. They are not cats. They will gulp it down, right? This is what they do, and this is for me an important gastrointestinal sign actually already, right? I asked the deworming, oh, did you ever leave the UK? Have you been abroad? Oh, no, yeah. We went to France last summer, but, and so then all the travel illnesses come up in my mind, all the red flags, right? So, but for me, it's important that the owner feels safe. So often I offer them coffee because I know, we need to be comfortable with each other. And then they will tell me, I have no chance as a vet to pick up on anything here.
I know a lot of the vets listening to this podcast work in smaller clinics where there's sometimes only 1 or 2 vets there.
Good.
And they have this possibility that some of us others might not have to create a space of calm and trust and give it a little more time to ask some of these questions. So I actually think that some of the smaller clinics are at an advantage in this case.
Absolutely, they are. Look, this is like going to your own doctor, right? If you think about yourself as going to a doctor, what would you tell them? If you feel that this is an arrogant prick, sorry to say that, you would not say a thing, right? You say your minimum base, okay, sorry, I have tummy ache or what, and that's it. You're not saying, okay, I have this and that add-on. So think about yourself. How would you would feel going to a doctor? And this is how you try. Why would you tell another doctor more than others? And this is the same, right? And the key is always to listen, to actively listen, and that the owner perceives you are listening. And at least I feel they are so grateful when you do that. Right. And then if you are not making them feel uncomfortable, not using too many medical terms, they will tell you more. Just speak open like we do now. Right. And then the solution will come, because then you will be able to create already from the history a problem list. And as soon as you have the problem list, you are on the right track to get the right diagnosis. Yeah. This is the key. Always, right? So the owner has the answers. You have to ask the right questions. You are Sherlock Holmes. You have to find these questions which are correct with your experience, and then you will understand which organ system is most likely involved. And this is now, of course, for me, was a surprise to hear about, for instance, the brachycephalic breeds, which I thought, it's breathing only. And then it came up, tuck, on this long list. And I was like, oh my God. So yeah, this has changed for me.
Yes. So we also have to be Sherlock Holmes in a sense that we haven't been asked a question. Because if the owner doesn't perceive it as a big problem and they come in with something else for a booster shot, for example, we actually have to... this is somewhat difficult. Also, just a couple of episodes ago, I talked about dental disease, and we sometimes have to make the owners aware that there is a problem, and that can be a tall order to bring them from 0 to 100 in just one setting, right? So we also have to somehow come up with the idea ourselves that this could be an issue.
Yeah. I always try to compare it with human problems. Let's say the dental problem, right? So we are aware it's not only because of appearances that we want to have healthy teeth. I think humans are more and more aware why it is important to have healthy teeth ourselves. And I say it's identical. It implies exactly to dogs, and they live now much longer than they lived decades ago. And this is why dental disease is now an issue and has a systemic effects. And I give them the evidence: increased risk of kidney disease, heart valve disease. And this is proven, right? So when I explain this to them, and I tell them also, of course, the latent toothache, what many people are not aware of, even though there is a fractured tooth, and he's eating fine, but when then suddenly a tooth has been extracted and they have new quality of life, they feel like a young dog anymore, right? And again, right? So, and this is this keeps me going, I must say. I know these discussions are hard, but don't forget, this is what we are here for. This is why we got this education, right? So we are on the side of the animals, and I'm not on the side of the owner, clearly, okay? That's
so this is also why I think it's important that we spend some time here talking about the questions and the way we approach these, because if they come in with a specific symptom, say PUPD, where they're just drinking a lot, and we have to make a diagnostic plan, and the owner is motivated to find out what's going on. Here, as you say, we don't have a specific test we can run and show them. I can't just take a dental x-ray and show them there's an abscess here. So it's important that when the questions are the most important tool here, that we spend some time on this. So, but moving on is when we have let's say we have an owner that is open to suggestions, and they say, okay, vet, I believe you, there's a problem here. Where should we start?
So you mean now in general for brachycephalic dogs, or what would you because I mean, this is for me, for instance, this was my problem, because of course, these patients come because of breathing problems, right? So this is also the most obvious for the owner, and most of the owners understand, especially after a hot summer, that there is a severe problem, because the dog has no other possibility than lying the whole day next to a pool or in the shades and can't move and is getting more obese, and they understand over time that there is a problem. So how do I see these patients? This is how it all began for me, is that, of course, I've been approached by the surgeon. Steph, this dog is also vomiting. What can we do? This dog has also diarrhea. This dog has whatever, regurg. This is probably the biggest problem why they talk to me, especially pre-op. Can we do something now? I think, well, it's a bit late. So, yes. And these are the tip of the icebergs. But of course, we are all aware that these breeds have many challenges: spinal disease, dystocia. They cannot even give birth most of the time alone, right? So there's so much going on, and where to start. But for me, basically, why I do see them is in almost 99% is because of gastrointestinal additional problems. And this is, of course, why as soon as I see a brachycephalic dog, whatever they are coming in for, I ask all gastrointestinal questions, right? So then for me, I specifically ask, I ask all the regurg questions. How is the eating? Is there any regurg, even if it's only white foam? Is it, when does it happen? How is the sleep? And of course, this is the next part, what I understood then. How is the sleep? Is it a fragmented sleep? Do they sleep through the night? Do they sleep? We have dogs, they can't sleep without a tool in their mouth. So there are many dogs who are so severe brachycephalic, they need to sleep with a ball in their mouth to keep the mouth open. So, and then they tell me, oh, this isn't he cute? He's so playful. He always wants to have his ball. And for me, my heart breaks hearing that, right? I think he can't breathe, right? So, and I explain it to them, and I explain it really in their words. And when they understand and the penny drops, I had owners, they break down. They really didn't know, right? They didn't know. And then they are very open to get started. So most of them decided.
So when they present with these GI signs, and you have a sense from your questions that this might be a brachycephalic syndrome instead, do you start by doing the basic GI workup with the Giardia test and Corona and what else we have to do now?
Yes. So the big thing with gastrointestinal symptoms is that the name is already, first of all, misleading, because it can originate already, of course, also extraintestinal. And I inform them from the start, according how they breathe. As if they have a clear breathing sound, I tell them, I can help you, but to cure this problem long-term, you will need to address the respiratory tract, because this is what the studies say. The respiratory tract is clearly linked to the gastrointestinal signs. And this is, we know now, because of shift of pressures. So with this breathing sound, a negative pressure is created in the chest. And this chest is leading to abnormal, let's say suction, almost like a Hoover on the esophagus. And the esophagus is already, anyway, due to many abnormalities, not functioning normal. So it has been reported it's not, there are many esophageal deviations, meaning it's not running straight in a straight line like in other dogs. It's also having dysmotility, so it's not transporting normally. So food is staying longer in the esophagus. Add onto this negative pressure. This makes everything more likely that we have these reflux episodes and so on, esophagitis. Addition to that, they found that almost all of these cases have a lymphoplasmacytic gastroenteritis confirmed in biopsies which have been taken without any form of previous stepwise approach as we medics do by surgeons in all these studies, but repeatedly being confirmed. So for me, I always approach them like any other gastrointestinal patient. I try first to understand what is there. Do we have regurg? Would be more a sign for esophagus. Do we have vomiting? This could be more a sign for gastrointestinal tract. Do I have diarrhea? I understand all the questions, large or small bowel. So I go through all these questions to understand the location. So as soon as I know that, and I really think it's a gastrointestinal tract problem, I do a full blood examination to understand if there are other reasons for an extraintestinal disease, right? So like you have, for instance, a hypothyroid cat. So this is not, of course, the standard brachycephalic patient, but of course they also have the Persian cats and so on have brachycephaly. Same problems, by the way. But they could have hypothyroidism and have gastrointestinal because of that. So just that we are on the same page. Then, of course, I rule out the common things are common. So I rule out Addison's disease. I rule out, I always do my gastrointestinal panel. I do a specific lipase. I do folate and cobalamin to understand if there's maybe already malabsorption or things like that present. And then the next thing for me, of course, is to do an abdominal ultrasound to understand, is there anything what I could pick up already on these examinations? And then there is nothing else for me to do than to start a stepwise treatment protocol. Why is this important and why do I not scope them instantly? And some owners are quite disappointed because they come for a scope and think I do all these big surgeries and whatever I do. It's important to understand that the gastrointestinal tract is responding stereotypically to various insults. So you don't know if the lymphoplasmacytic inflammation you might confirm, which so many people think instantly it's IBD, is linked to either a food responsive disease, an antibiotic responsive disease, or a steroid responsive disease, or maybe something completely different, or a combination of these. So this is why you never start with biopsies. I rule out all the other things extra outside of the intestinal tract, and then I start with the intestinal workup. And this is always stepwise.
Do you spend time on a food trial as well? You mentioned food reaction, so and that can take months to go through.
Yeah. So it depends how severe the symptoms are. So, and it depends, of course, also how old the patient is. So every patient under 3 years of age could still have a significant food allergic component. And this is, I have many who are responsive with that only, right? So of course it takes up to 4 weeks at least to see a response most of the time. And I usually try to combine this. It depends now, of course, what is the initial presentation? Are they more here because of regurg or vomiting, or are they more here because of diarrhea? Then sometimes I add on, to overcome quickly this waiting time, a short antibiotic course to rule this out at the same time, or I add on anti-reflux medication to see if this just did gain a bit of time and to make everything better. And so often, I must say, there is many owners tell me already respond very quickly, but it depends on really the severity of signs. So the more severe it is, the more I shoot higher, let's say, with a few more cannonballs at the same time, just to understand what could be potential triggers, because of course we must improve the situation. And I mean, to be honest, as soon as I see them in the referral clinics, they have a history. Indefinite, right? So I often see cases they are ill for years.
Yes,
and long.
I know because you told me so, but I have a couple of patients that are running chronically on these acid modulators for vomiting, and I can so understand that is not maybe a good idea.
No, absolutely not. And this is, I mean, this is a bit of my, it's really close to my heart, because especially the brachycephalic breeds, of course, present with a long list of medications. So first thing, usually what I do is most of them to stop them as soon as I can. But yes, the biggest problem is, of course, if they come to surgery for a breathing problem, almost 100% of Frenchies, for instance, also according to studies, have gastrointestinal signs. And these gastrointestinal signs in brachycephalic breeds are mostly linked to an upper gastrointestinal problem, meaning regurg and vomiting. So these dogs have all sorts of antacids, proton pump inhibitors like Omeprazole for ages. And we know now from human studies, and we compared this in animals as well, that this is actually doing more harm than benefit. Why? What are you actually doing? Let's stay, for instance, with the most common one, at least in the UK, this is the Omeprazole, which is being given for ages, and everyone thinks, oh, I have a vomiting patient, I give some Omeprazole. What is Omeprazole doing? Omeprazole is a proton pump inhibitor, which is lowering the acidity for a few hours per day. So if you give it once daily, if you are lucky, your acidity is reduced for 3, maybe 5 hours after, and that's it. You have 24 hours, okay? The problem is that with lowering the acidity, you also change the whole microflora. This means all the bacteria suddenly have time to overgrow. You change the whole system. And we know over time, this is leading to a significant malabsorption of certain nutrients. And this is proven in humans, leading to osteoporosis, even calcium, magnesium, cobalamin, vitamin B12 is malabsorbed over time. You actually have deficiencies, and you have a decreased homeostasis. Your whole microflora is changing. This is one reason why many animals experience more adverse gastrointestinal signs when you start these medications, because you actually create a dysbiosis. Right? So, and now here's the other trick in these patients. Brachycephalic breeds, even though not clinically breathing loudly, often have low magnesium. Magnesium is essential for breathing, especially also during sleep. In humans, it has been proven that the sleep apnea, so a state in which you are not breathing or have an obstruction during breathing, which what we all know is snoring, which is one pre-form before that, and what we sometimes think it's cute in dogs, it's actually not, is linked to a low magnesium. And if you now give these patients, even though they breathe normally and have confirmed low magnesium, give long-term these medications, you make everything worse, right? So you not only trigger a dysbiosis, you trigger potentially malabsorption. You make a small intestinal bacterial overgrowth, maybe even worse. And you might even hinder the absorption of magnesium, which is linked to clearly worsened sleep and the risk of hypertension, same as in humans. It's actually so similar to humans that the English bulldog is used as a model to study this. So close we are. So we are together in this, right? So, and this is all linked. And this is why if you prescribe anything, you prescribe it for a short term to see if there a response. And then you start digging for the underlying factors. Does this dog maybe have reflux because of IBD? Then I need to work this up. Does he have reflux because of food allergy? And so on. So I prescribe it maximum for a week, 8 days, and I stop and wait.
Some of my patients are also on steroids because of, and I'm completely acknowledging that I haven't worked all my patients out in this manner, right?
This is okay.
So I have some patients that I suspect have some kind of allergic disease, but the owner is not motivated. And what we can end on is them giving a tablet once or twice daily, right? So they end up with a somewhat lower dose prednisolone or something similar to keep the intestine at peace and the itchy paws, and then everybody is happy, but maybe not.
Maybe not, absolutely not. Especially hearing skin signs at the same time, which is the most common sign for a food allergy, makes it highly likely that there is an underlying food allergy present, and the highest steroid dose will never ever help here to resolve problems. So it's our task to explain to the owner that I can increase the steroids and more and more and more, but the risk of high steroids are also there, right? So it's like you create an artificial Cushing situation, you create a higher risk of thromboembolic disease, you create a higher risk of any form of infection. And you could change this severely in lowering the antigen burden on this patient just feeding a hypoallergenic diet strictly, and you can reduce the steroids. So try to be thorough as much as you can. I know this is, I totally feel for you. And I'm not saying every patient needs a scope. I'm saying this would be ideal for me. I'm telling you, however, that 99% of the cases I see for gastrointestinal workup as a referral, they have not been worked up from the start thoroughly, and they have been on medication over years. And I'm telling you now, these medications can do more harm. So it's our task, again, first of all, no harm, to prescribe medication thoroughly and critically. And also, like we do now with antibiotics, right? We are thinking more. I think vets in general, if I want to say, please, I think we don't lightheartedly prescribe antibiotics as do human doctors. Sorry to say it, I'm quite a bit judgmental here, but it's personal experience. It's not the vets who prescribe all the antibiotics, although we are always blamed for. But for every medication, we should be critical. Can I really help here? And if I don't see a response in a week's time, why should I continue this medication over years, right? And trigger even more adverse events. So this is what I want to encourage to think about.
Yeah. So let's say that we talk to the owner or maybe to ourselves about the medication, trying to taper a bit off with some of them. We run a blood sample, and it's fairly. I think that side of things are fairly straightforward, and we shouldn't go into medical diseases unless they're completely relevant to the brachycephalic dogs. But if there's something in the blood work, we would have to go in another direction. How about fecal examinations? How broad would you go? How would you just do a basic flotation to look for a tapeworm and a Giardia and then be done with it?
Yes, I love this question, because I'm honest with you, I'm not doing any fecal anymore, except I have a cat with suspicion of trichomonas. Yes, not any fecal. All the studies confirm, and there are many recent studies, how sadly there is hardly any proof that a fecal exam, especially fecal culture, makes any sense at all. First of all, worms are shed, every day on a different basis. That's why you have the 3-day collecting time. They are also, I'm afraid, within the feces sample itself, stick to certain areas. So they are not all at one spot spread evenly. They are maybe one in one corner, not in the other. So you can even miss that. In my case, I always just deworm them thoroughly to be on the safe side. I'm not relying on worm counts, not at all. And you know what? So often they are better with that. So it could be I'm seeing a patient, let's say, with mixed diarrhea. I do the deworming, and after that, they only have small bowel diarrhea. This is for me important for the workup, right? Because then I can absolutely see a difference here, what's going on. Then, for instance, also I see a low normal cobalamin. Cobalamin is already considered deficient if we have values under 400 nanogram per liter, which is still within the reference limit, because we know now this is on cellular level, there are deficiencies. So for me, these are important signs, right? Don't rely on fecal samples. There's also the problem that I see many send in fecal cultures. This is the only time I do that if I have a raw meat fed dog and I have concerns for human zoonosis, Campylobacter, and so on. Then I do a fecal culture. This is the only time. The other benefit, so the other understanding for this, we must understand that in the recent studies, which I think are super interesting, understanding the microflora of a dog are very individual. There are big individual differences. And what you get out in the end is a mixture of all the different floras of all the different areas: duodenal, jejunal, ileum, colon. They have complete different, even within their own system, flora, microflora, and you get a mixture. So the likelihood that something dies on the way out, the likelihood that this is the true mixture of your whole gut and you find something here is very, very low. And the studies confirm there is actually no benefit in doing a fecal culture and fecal flotation rather than to treat thoroughly and to rule out a human zoonotic disease. In the UK, I'm afraid, they have very good reminders. So the GPs often send out your next deworming is due on a monthly basis and so on. But they use over decades sometimes the same deworming medication. They have always the same every month. And of course, this creates resistances. So for me, although the onus tells me I have been thoroughly dewormed all my life, I always repeat a different deworming. So for me, this is usually a 5-day course of fenbendazole, for instance, combined with a week later, 10 days later after finishing this, of milbemycin, for instance. So I kill several stages of worms with several products, so several different and this is, for me, number one step in any form of diarrhea, gastrointestinal patient, or weight loss to rule this out. Mm-hmm.
Yeah. So it's nice to hear another perspective on this, and we have fairly strict regulations on medications here in Denmark. And I'm not in any way qualified to talk about this, but I think that the regulations are more loose in other countries.
Yes.
And now we are just in the midst of a EU something, and everything is hyped up on that. So that is a discussion for another day. But if we keep to what is just our patient and what you think there's evidence for, you would rather treat patients, even though you know you're going to treat patients that didn't need it.
Yes. No, because look, a patient is never sterile. It's just with regards to worms. No patient is sterile. And Giardia are usually secondary to something, right? Think about this. Tests can be, there's no such thing as a test which is 100%. Most of the time, hardly any test is 100%. And the risk that I miss out on something is too high for me than the health benefits of a patient. So do I do more harm or more benefit? And for me, I think I do more benefit. My own experience tells me, and the studies confirm this. So I'm afraid in this case, it's good that countries are critical about medications. And I absolutely agree. We must be more critical with everything. But of course, my status is, of course, a bit different than I work in these late stage of a patient's sickness story, let's say. I think what should be stopped for sure is to give preventive anthelmintics too often. So I'm not agreeing with a monthly regime if it's not a immune compromised patient or any other reason why they would need longer, for instance. So this is something what I say, and of course, if they're not on a raw meat diet, which is the next craziness. Yeah. Mm-hmm.
I have another question, and this might be somewhat a tangent to run off on, and I promise I will get back onto the workup in a second. But you said Giardia is usually secondary to something else, and I have a couple of owners that comes to me and tells me that this dog had Giardia in the early life. It was 7 months old, and it was just diarrhea everywhere, and it was difficult to treat. And now the stomach is ruined, so he cannot eat anything other than his regular food because it was destroyed by this Giardia. And I've heard this story actually retold by veterinarians as well. So I'd like, in the context of brachycephalic dogs and why that is relevant to think of the GI signs in these kinds of patients, can you maybe talk a little bit more about the Giardia side of things?
Yeah, I mean, Giardia are not necessarily, at least I'm not aware, more prevalent in brachycephalic dogs, but Giardia, like any other parasite, are here if the immune system is compromised in any way, right? And if I hear, especially in a youngster, that they had this, for me, it's already the question, what is wrong with the gastrointestinal tract that they had, that it favored a parasitic overgrowth? I asked them specifically diet history. I have this often in rescue cases. What happened there? And I would say most of the time it started already very early that they had an underlying food allergy, and it has not been picked up on that. Right? And this is what favors then the overgrowth of certain parasites. And of course, also I asked all the management if it was a puppy, how was mommy? How was the situation from the breeder? Tell me more. And I asked them, how was this? And I already get so much. This is a husbandry thing, right? As a Giardia, also high risk of reinfection. Especially there are studies who show if you treat for Giardia and you don't wash the hind limbs, for instance, at the same time, the eggs can survive there. And this is a high risk of reinfection. And I try also to understand, do I have a reinfection or relapse? Right? This is a difference. So, and of course, our problem is that they could have more also resistances with regards to treatment. I try to understand what has been done as a treatment. But I always, for me, in my workup, I try to understand why did someone get that? I try getting behind this question. I'm not thinking this dog had just Giardia. Giardia are there. They're everywhere, right? Why do I not get Giardia? It's even a zoonosis for me. Because my immune system is healthy. And why is it not working for this particular dog? What are the problems? And now, yes, of course, the stomach is ruined because this is how IBD works, right? We believe now that IBD starts in early childhood. They have either predisposition or a latent food intolerance or food allergy, which proceeds over time in a form of a chronic inflammation, a permanent trigger. And this is then leading to the IBD. And yes, this is probably right that where vets say that in that way, but it was not the Giardia from the start. It was something else. It was the tip of the iceberg.
Yes. So this is, of course, one of the most important, as I hear, if I hear you right, it's one of the most important differentials in these brachycephalic dogs. Or is it?
It's for me as for me, I see them mostly as gastrointestinal patients. And of course, I try to rule out as much as I can. If I see a young dog and I see the whole picture, of course, I see them because of regurg and vomiting most of the time. Giardia would mean more large bowel diarrhea, mucurate, fresh blood, whatever slimy stuff. This is the classic Giardia diarrhea, right? Could also be small bowel, of course. But these are the things I try to localize already my lesion with the history, what I get, right? So, but for the brachycephalic ones here, I mean, they have all reasons to have parasites because they are so on such a high stress level all the time. So, right, this is what we know. They could have worms, I think, non-stop. So for me, they are already immune compromised in my eyes, just because of the breathing.
So then we move on to ultrasound, and instead of doing an endoscopy on them, and that actually somewhat surprised me when I saw that you recommended that first, because
Yeah, absolutely.
I
Oh,
was
yes.
first of all told that doing an endoscopic exam was the way to go, and at the other
Wow.
side is that why would you do an ultrasound on a dog with a breathing problem? But we somewhat touched on that. But can you maybe talk a little bit more about why you would do ultrasound as a first
Always
thing?
ultrasound, always. This must always come first. You must understand what's wrong with the guts. You must understand, is there another reason why someone has gastrointestinal signs? You could have a pheochromocytoma, for instance, right? You could have anything. You don't know anything about a patient just from your bloods and from outside. And now here's the most important reason why I do it. I try to understand, is there a thickening of a certain area of the guts? How is the motility? How does the mucosa look like? And if I see, for instance, the muscularis, so the outer layer of the guts, it's much thicker, I can give up on scopes, because gold standard to diagnose any gastrointestinal disease is a full thickness biopsy. I'm not starting going from inside and grabbing a bit of the little superficial layer. No, then I need full thickness. If I see the muscularis is thicker, the problem is outside, and I can't reach it with my scope from inside. I cannot just poke a hole in there. I need surgery for that. If I see the pancreas also looks funny, which is a very difficult diagnosis, for instance, to diagnose pancreatitis, I might even, at the same instance, take biopsies here. If the liver looks funny and I have a mild liver parameters elevation, which also these patients, by the way, have commonly because of hypoxia stimulates ALT, and so on. So maybe I even need to get some bile tests done, which or some more liver samples, and so on. There are so many reasons. I'm afraid often they need a next lab. Yes, and I do. This is part of my workup. I never start a biopsy, endoscopy, never. There's a long way to go before we do that. And of course, they have a breathing problem, but maybe they have also a breathing problem. Maybe the breathing problem is worse because of the reflux disease. And this is what I need to understand. Maybe I'm lucky enough, even on ultrasound, to see an ulcer. Rarely, it's very difficult to diagnose the big boys. However, you could see even, right? So it can be missed easily though, but things like that. So there's so much information in ultrasound, the adrenal sizes, right? This is God forbid. So I encourage, you must do an ultrasound before you scope. And if you should do a scope at one point in your life, never rely on it looks normal and don't sample. You always sample 8 to 10 samples per location, actually. So just that you know how much you need to know what's going on. So this is, if you do a scope without sampling, it's for me it's a cross mistake. So this must not be done. You do actually more harm, risking the GA. It always looks normal, and then there is the problem.
Yeah. So is that the proper workup? So let's say that we've done what we talked about for the last a little hour or so, and we actually decide that this needs a brachycephalic surgery. Is that now, or should we do something else beforehand?
No, I'm afraid surgery is treatment number one. So even though, because especially we know that respiratory signs improve in over 95% of the cases, and with after surgery and the gastrointestinal, sorry, I rephrase this again. So the gastrointestinal signs improve clearly after the respiratory surgery. So what we do in the clinic, I'm working with my BOAS surgeon. We say, okay, we have a plan. We might change already the diet to gastrointestinal diet, or maybe a hypoallergenic diet or things like that. But you do your respiratory stuff first. So the surgeon starts here first. This is for me as a medic, the only time when I recommend surgery first, I'm honest, is the only time. This is the only patient I say respiratory surgery first. As soon as they can breathe, all the pressure will shift, right? With this decreased thoracic pressure, you must understand, this is like a compartment syndrome. right? Compartment syndrome is like you get hit by a car, you have decreased changes in pressure in your chest and abdomen. And this is a similar situation. If I can elevate that, I already changed the whole workout. If they have still gastrointestinal signs after that, then my task starts. But what we do basically before all that, so I already speak to my surgeon. We do this together as a workup. I already tell her, and she knows now, she doesn't even ask me anymore, I want the full bloods before her surgery. I want full gastrointestinal panel. I quickly check in, is the deworming up to date? Is there what has been done food-wise? So we change to a gastrointestinal diet most of the time. Then the surgery takes place, and if there are still signs after, then I see them again. Mm-hmm. So this is in my workup. So, but scope for me is the last thing, right? If I have severest signs, then I do already while the surgery is done, or before or after I do the ultrasound in the same anesthesia. Mm-hmm. Yeah. This is how we handle it.
So this is maybe a little bit outside the scope of this podcast, but in surgery, do you usually do both the palate surgery and the nasal surgery at the same time, or do you do one and then wait the next one?
This is a question. This is a question for the surgeon, but we do. This is what everyone probably individually prefers. But in our situation, so in our surgeon does everything as much as possible. So at the same time, the less anesthesia, the less risks, especially also for reflux, right? So every general anesthesia is a high risk for reflux, especially in these predisposed patients. So we try to avoid as much anesthesia as possible. But if it's needed, then it's needed, and yeah. This is what it is.
And do you, as an internal medicinist, is that a word? Do anything specialist? Do you do anything post-surgery? Would you start these acid inhibitors or start steroids or stop steroids?
This is a good question. So it's, of course, the biggest reason to have a reflux disease is anesthesia, right? So we always, if we can, start them a day or two before already on antacids, so meaning or proton pump inhibitors, so anything what lowers the risk. So at least 24 hours before we try to give omeprazole or add on a medication which is increasing the sphincter competence. So because reflux occurs because the sphincter is not closing properly due to whatever reason. So we give them omeprazole and cisapride in combination at least 24 hours before the appointment. And then we give it IV in the morning when they come in, and then surgery is usually a few hours. So anesthesia is a few hours later, so they come very early when it's still quiet. Then we give the medication IV. We know in studies esomeprazole would be preferred, is better, and then omeprazole IV. But there is, I'm afraid, still no protocol which is effectively stopping all reflux episodes. You can just reduce the frequency, but there is no medication which is stopping that. But of course, we also try to have a bit of management. So they are lying a bit higher on the front that you try to avoid, of course, with gravity and reflux episode. They are not lying basically in flat and on the side or things like that. And they get metoclopramide or whatever we have, cisapride, IV during their whole stay. We are just aware of reflux. So the team is trained for that, to monitor for reflux. We have suction prepared and so on. So these are the things. So we are on high alert for this because reflux is the biggest problem. And the problem with esophagitis is, especially reflux esophagitis, you can have a severe worsening or the clinical presentation a week later, right? This time is significantly delayed in seeing that. And I often then in this time already dispense anti-reflux medication just because I know this breed has more problems, and I know from the history the dog already had regurg or whatever, which makes it, of course, more likely that the esophagus already has a pre-injury, right? So, but this is not more what I can do. The problem to address must be first breathing. Then it's my task to do the next thing. Mm-hmm.
So that's actually quite important, because I know most maybe that listen to this podcast would this will be a referral task. So they refer off the dog for surgery, but they will get them home for checkups afterwards. And if this is still important 5 days later, the first
Yes,
will need to know this.
Yes, it's super important. Don't forget, esophagitis signs can be severely delayed. This can be instantly, can be severely delayed a week, 10 days later after any anesthesia. If you see signs, also, for instance, what I was so long misled by, vomiting of white foam, right? I thought, is this a bit of a tracheitis? Maybe they were even retching a bit. And I thought, this is maybe because of the tube or something, right? So we use always a GA in these patients. We never sedate because of the reflux risk. So we always have a GA, meaning intubation in these patients. And this vomiting of white foam is one of the key signs for esophagitis, right? I didn't know, because I thought, I always will have some bile or some yellow stain or something involved. No, white foam is enough to consider this as a esophagitis already, right? So, but of course, listen thoroughly, or is it still more a cough, whatever your patient is more prone for this. But just don't forget, the biggest reason to have in any patient a esophagitis is anesthetic procedure. Anesthetic procedure and reflux, and the reflux is due to anesthesia. So so it goes.
Yeah. So that actually marks the end of it. So the patient is home, and 10 days later is still okay. So everything is fine now, or is it?
It is. So yeah.
Okay, good. Thank you for coming.
No, I hope so. Yes, so no. But this is now depending. Usually we give them 4 weeks after surgery to give the gastrointestinal tract and everything time to heal. Because you have a swelling, right? If you do surgery of the soft palate, there is a swelling, there's painfulness, there's a retching, there's a pharyngitis, and so on. So we give them 4 weeks, and then I take over. If there are still problems, it's me who sees them.
Good. So is there anything else that we need to touch on for these patients, you think? We touched on quite a lot of things today, more than usual, actually. So,
yes, I'm so. Oh my God, I'm sorry. I hope I did not overload anyone here. Everyone hope had a long.
But it's a good thing. It's a podcast, so you can be kind, rewind, and then listen to it 10 times.
It's amazing. Hey, I just want to stress in this talk, they have 1,000 reasons to die. They have 1,000 reasons to die. It's not our fault if this happens. However, it must change, okay? I'm asking everyone who is listening to see these patients with new eyes, to resensitize ourselves, to take this breathing seriously. We have so many things not discussed now: disturbed sleep, increased inflammatory parameters, increased sugar values because of latent stress, and so on. Hypertension, so many things. There are so many things you don't know, and so many things we can't test for appropriately. I ask you also, as a human, to be open, have a kind heart, although I know it's a very big frustration of owners, as you started initially, yes, and of pets. They are difficult to handle. Sometimes you can't muscle them. Sometimes they maybe are aggressive because they are not well kept and so on. But you don't know what they are fighting for in everyday life. If you say, eat, sleep, go fishing is your hobby, this is how you want to live your life, I tell you, they can't. Be patient. Yes, they can't eat, they can't sleep, and they definitely can't go fishing, okay? So I'm asking you to be open-minded, be patient, prioritize these patients, take your time, okay?
Well, thank you very much, Steph. I need also, of course, to ask you if I need help with these patients. It might be too large of a long travel to refer them directly to you, but I know you can help us anyways, right?
Anytime, also virtually, and also send me messages, whatever works for you. Anytime, I'm here to help because it's my heart's desire, and I'm really a vet with all my heart. I would like to improve and help as many pets as I can. I'm willing to share my knowledge with everyone who is ready to listen. I'm more than happy to discuss. Please do contact me if you want to anytime.
So one thing I know that is good with the service that you also offer, or the service you're part of, is that if I need help with a patient, I don't just get help with that specific patient. I actually, I know that you and your colleagues are trying to teach in the same, alongside helping with a concrete patient. You also would like to teach us how to approach these and learn something.
Yes, I'm here really for everyone who wants to share their experiences and also wants to get some advice. This is not, look, I'm not holding back. It's a one world, one health approach, and I think in every country we are struggling with the same problem. So what is it also, I think, we as vets, we must stick together to improve our own situation. Every vet I heard of is now struggling, and the biggest frustration is not only not to be able sometimes to provide adequate care for ourselves, but also, of course, to have frustrating patients. And if I can help you, I would be so happy to do that, and we can work this out together 100%.
Yeah. Well, thank you very much.
I thank you. It was a great pleasure talking to you. Thank you so much. I had a great time.
Husk, at du kan finde links og noter til dagens afsnit på SIVP.dk og så episodens nummer, for eksempel SIVP.dk/1. Og føler du et behov for at udvide dine faglige færdigheder, uden at skulle tage en hel dag væk fra familien og fra klinikken, så har jeg nogle online kurser til dig. Du har måske hørt mig sige det før, men du kan få en hel måneds gratis adgang. Og det kan du få med en speciel kode, som jeg ikke deler noget andet sted end her i podcasten. Og det er fordi, at dig, der lytter til podcast, du er noget helt særligt. På SIVP.dk/XYZ får du 4 ugers gratis adgang til kurserne og protokollerne på hjemmesiden. Alle kurserne har specifikke læringsmål, så du ved præcist, hvad du får ud af den tid, du investerer i det. Du kan for eksempel lære at lave en regelret neurologisk undersøgelse og bruge det allerede næste gang, du er på klinikken. Du kan også lære at tolke blodprøver, og du kan lære at lave et godt finlåsaspirat og tolke det sikkert. Der er meget mere, men kig over på SIVP.dk/XYZ og tilmeld dig den gratis adgang, så kan du se, hvad du kan lære og bruge allerede næste gang, du er på klinikken. Udover alt det, så får du også adgang til et lukket online forum, hvor du trygt og sikkert kan dele alle dine i gåseøjne dumme spørgsmål. Dem er der selvfølgelig ikke nogen af. Men vi er sammen om at lære. Du skal ikke lære alene. Vi er sammen om at blive bedre. Og så ved jeg godt, at der er nogen, der er bekymret for at tilmelde sig et medlemskab. De er måske bange for ikke at få det brugt. Og jeg ved godt, at du som lytter til det her, jo går op i din faglige udvikling, for ellers havde du jo ikke lyttet til podcast. Men skulle du nu alligevel være bekymret for at glemme at melde dig fra, når din gratis måned udløber, så skriv lige til mig. Jeg har nemlig resultatgaranti, og det betyder, at hvis ikke du ser resultater i din hverdag, så skal du selvfølgelig ikke betale for noget for at have været på kursus hos mig. Se på SIVP.dk/XYZ for at tilmelde dig en gratis måned med det samme. Vi ses!